So I'm going to talk to you a little bit about what lay people refer to as stroke in the eye. And that is a very lay description because we have two different circulations that can be involved, the posterior ciliary circulation, and so that might be non-arteritic anterior ischemic ophthalmopathy, or it could be the retinal artery circulation, either a branch retinal artery occlusion or a central retinal artery occlusion. Both of these, we tell patients you had a quote-unquote stroke in your eye. But non-arteritic anterior ischemic ophthalmopathy is like a small vessel disease. We don't do any echo, EKG, carotid Doppler, or the embolic workup for typical NAION because it's not an embolic disease. So even though embolic NAION does exist, this is small vessel ischemia, hypertension, diabetes, high cholesterol, smoking, weight, sleep apnea, all the usual things. These guys here, the retinal artery occlusions, however, you'd have to do the stroke workup on these people because that is what the stroke team would consider a stroke. So when we tell patients, lay people, they have a stroke in the eye, NAION is not what the stroke team is thinking about as a stroke. This is a stroke in the eye. And so in an arterial occlusion, you're going to see the segment that's involved. So in a branch retinal artery occlusion, there might be an embolus right there. That whole segment supplied by that branch retinal artery will be whitened and have pale retina ischemia. And if you have a CRAO, the whole thing will be out, but we'll be able to see in the dead center of the fovea a cherry red spot. Now, with that in mind, the acute phase ones are so easy, right? In NAION, the disc is swollen, sector or diffuse. In branch retinal artery occlusion or central retinal artery occlusion, we see the pale retina and the cherry red spot. The hard one is if it comes to you 6 months later. And if it comes to you 6 months later, both NAION and retinal artery occlusion will both look the same, optic atrophy. And so you might mistake this optic atrophy as a primary optic atrophy where the problem is in the optic nerve, and you might mistakenly tell the patient, oh, you must have had 6 months ago NAION as the cause of your stroke in the eye nerve, acute unilateral loss of vision, RAPD. However, optic atrophy can occur if you kill the retina. So if you have a branch retinal artery occlusion, you'll get a sector of pallor. And if you have a central retinal artery occlusion, you'll get diffuse optic atrophy. And so the way to differentiate the old BRAO, old CRAO from old NAION in a patient who has optic atrophy is to do OCT. And as you know, optical coherence tomography gives us a very beautiful picture of the layers of the retina. And if in the fovea, we can see that in NAION, we're only losing the nerve fiber layer and the retinal ganglion cell. But in a retinal artery occlusion, we're going to lose all of the inner segments, which are supplied by the retinal artery. However, because the choroid supplies the outer retina, in a patient who has a branch or central retinal artery occlusion, the outer retina will be preserved and only the inner retina will be atrophied. So instead of seeing a nice layer cake of our retina, we got one side that has all the layers and the other side that only has the outer retina remaining. All the inner layers are gone. And so if on the retinal OCT, we see the inner retinal atrophy and loss of these parts of the layer cake, then we're going to change the diagnosis from stroke in the eye from old NAION to stroke in the eye from old BRAO in a sector atrophy or old CRAO if we've got diffuse inner retinal thinning. And so OCT can answer a question about an event 6 months ago. Was it stroke in the eye from NAION or stroke in the eye from RAO?